Hello friends, I've been invited by the Doc Plus community to meet you all and talk to you all on the topic iatrogenic ectasia prevention and management. I'm the medical director of the Eye Foundation, which is a group of 10 hospitals, and I work with my husband, Dr. D. Ramurthy, who's the chairman of these n number of hospitals, and with 45 strong doctors team and paramedical staff. So going on to my topic, iatrogenic ectasia, prevention and management, is my due in the next 10 minutes. So essentially, what came to light was as LASIK surgery evolved, up to 2007, there was a gradual peak of the number of surgeries being performed in a study done in US and a similar study done in Europe. But as after 2007, there was just not LASIK alone, which was reigning the market, but then came in resurgence of surface ablations and phakic IOLs. But what was interesting during this period was there were 300 eyes were diagnosed to develop an iatrogenic ectasia, and believe me, it was in a mild and moderate myopic group. So that threw up a whole lot of confusion and quandary among the proponents of refractive surgery, that there has to be some risk factors which have to be identified. And as you can see on these slides, these were the different risk factors. Of course, high myopia, ablating too deep, or creating a thicker flap, or having a residual bed less than 250 micron, or if your cornea is thin, and especially in a younger age group. There were also ectasia risk scoring systems which were understood better, that how to look at those inferior steepening of the cornea, those skew deviations, that very thin cornea, and that corneal thickness which was getting from anything below 5'10", going on from normal to a grade 1 abnormal, grade 2 and grade 3 thickness of scoring systems. But what came to light in 2014 was the information that the percentage tissue altered had to be taken into consideration. And a percentage tissue alteration is actually flap depth plus ablation, flap thickness plus ablation depth divided by CCT. And it was said that a PTA of 40% or more was a major risk factor. In other words, it would indicate that there was a 97% probability of developing iatrogenic ectasia. But while there was an explosion of this information, there were proponents of like Santiago et al. Who came forward and told us through in number of studies that the PTA was not the holy grail of refractive surgery. Yes, it was definitely to be looked on as a major risk factor because there were so many patients world over who had had a PTA of more than 40 and had not developed iatrogenic ectasia. So you could just club it as one major risk factors along with the others which I have already elucidated. But what remains most important to be noticed is that we keep going back and looking acutely at the topographic abnormalities, learn to pick up those form frustae keratoconus, look at the overall D, and if that overall D is in the red, it definitely indicates suspicion. Look at what the different topographers have to offer, that Galili helps you pick up an early form frustae keratoconus more than the other topographers. But we also came to understand that there were different tools which would help us in early detection of keratoconus. Like if there was a higher order aberrations was increased, especially the vertical coma, which would draw attention that there was something more sinister hidden in that cornea. If you look at the corneal biomechanics and the deformity, basically the elastic recoil of these corneas goes because of the lack of rigidity in these eyes, and that could be, if that could be picked up and measured, that would be one more indicator in telling us that this cornea was weakening. Or when you look at the epithelial thickness profile or the Bowman's membrane thickness. So essentially there were different tools. The earlier one was the ocular response analyzer, and then came the Corvis, wherein they judged the deformability of the cornea, the deformation amplitude was judged, and this helped us indicate that there was something more than abnormal happening in these eyes and have to be immediately treated with great caution. The Corvis What here, this is a typical map which shows you a frank ectasia, and this is further added on with the information on the balance that the overall D is on the red. But then what Corvus does is, it combines the biomechanical information along with the pentacam details, and the corneal biomechanical index in this particular case in the green. The bad display is in borderline green, but the TBI or the tomographic biomechanical index is in red. So this indicates that my tears have become very dry. Indicates that we have to look at this with great caution, and TBI is definitely statistically significant in picking up form fruste keratoconus. The other information which we had was that if you could look acutely at the epithelial thickness profile, the epithelium tends to get thinned out at the apex of the cone. If you're able to pick it very early on, this would be one more clue at this eye is a probable ectasia and should not be taken up for the laser vision correction. Again, if you have access to the Bowman's layer thickness mapping, it would be able to note the disintegration in the Bowman's layer even before changes are appearing on the stroma, and this would again be a clue for us to look at a probable iatrogenic ectasia. Now, taking you through how you would manage it. This is an ectasia which was LASIK was done in 2008 for a moderately high myopic error. The OpScan topography said everything was all right, and the patient comes back in 2014 with an absolute frank ectasia. So then what happens? Taking you on, then you need to look at how would you visually rehabilitate these eyes. This person has a frank ectasia, a massive drop in his BCVA, and needs to be tackled to the best of our ability. So at that point of time, the only thing we thought of was to do a cross-linking to safeguard this eye. But you can't be random in how you deal with this. We need to have a management algorithm. Would I just fit a contact lens to these eyes and wait? Or would I go further and look at this ectatic eye and assume that there is a greater chances of progression rather than waiting for the ectasia to progress? Would I cross-link it at the first instance? Once you've decided that cross-linking is a mainstay in iatrogenic ectasia, we need to be cognizant of the fact that there is a difference in the pathophysiology in how the ectasia performs in these eyes which have been already undergone laser vision correction. The diffusion of riboflavin itself is defective in these eyes, and let's understand that we are cross-linking the flap, which does not contribute to the biomechanical strength of the cornea, and besides having ablated these corneas, the corneas could already be thin. So we understand that cross-linking is not going to be majorly efficient, but that's the major tool we have. But we have come forward now, we understand that just doing a cross-linking alone is not sufficient. You could even go and regularize this cornea by removing just max 50 micron of the tissue. But we need to remember, we are ablating the flap, but then it's a conical eye. We need to regularize the shape, make it as aspheric as possible, and we largely would treat the centered cones. Now, we know that cross-linking has a stiffening effect of the cornea and prevents progression of keratoconus, but if you could combine it with a refractive procedure along with the cross-linking, then you would have stability along with improved functional vision, and that is what we call as CXL+. So essentially, in a topo-guided PRK, what you're doing is, you are doing a combination of myopic and hyperopic treatment. In other words, you're flattening the cone, the steeper cone, and lifting up the surrounding area by doing a hyperopic ablation there. So you have a larger and a flatter cone which responds better to the biomechanical strain of the intraocular pressure in this eye. And as you can see this difference map, it has a central myopic ablation and a mid-peripheral hyperopic ablation. So this was a frank case of iatrogenic ectasia where the uncorrected vision had dropped down to 624, and this patient underwent a topo-guided PRK with cross-linking and had an improvement in his uncorrected vision to 6/9, which was the way to go. The next question which you ask is, would you do a combined cross-linking and a laser topo-guided PRK? Of course, it makes sense to do it, because why would you do cross-link that eye and then do a topo-guided PRK and remove the cross-link tissue? The whole purpose is defeated. Besides, we need to know that in a cross-link eye, we do not know how the laser is going to perform, because the nomograms would have not been defined for a cross-linked cornea. And the other advantage which you need to keep in mind is that by doing a topo-guided PRK first, you are removing the Bowman's membrane, and then when you cross-link these eyes, there's a better diffusion of the riboflavin, which allows us to think that simultaneous topo-guided PRK with cross-linking is the way to go in these iatrogenic ectasia eyes. Then the next question you may ask is, would you do an alcohol debridement? Do you do a mechanical debridement, or would you do topo-guided the PTK of these eyes? It makes sense to do a PTK because you would uniformly remove 50 micron of the tissue and make the cornea a little more aspheric, and by that itself improve the BCVA to an extent, and then go ahead and cross-link these eyes. So we conclude that we would do a PTK with cross-linking. Now, there are newer modalities which are coming up, like doing a customized cross-linking, because we now understand that keratoconus is more likely to be a focal disease. So, if you could give more energy overlying the cone and lesser energy in the surrounds, which makes more sense. And there were different designs which are configuration of treatment, like either doing a concentric treatment with more energy in the center and lesser energy beyond, or would you do an arc treatment like a center concentric rings for a centered cone and arc treatment for a decentered cone seemed to be the way to go. We came to understand that you could do cross-linking with topo-guided PRK, you could do cross-linking with Intacs, you could do cross-linking with the phakic ICM. So then the next question is, when would I do intracorneal ring segments or Intacs? So when you are faced with an eccentric cone, the cone is decentered. So you need to push up the cone to a no more normal physiological position, and then you should cross-link it. So for this, the intracorneal ring segments would be effective. So this is a case of a post-LASIK ectasia. So you need to, and you know the keratometers are going to be steep and the patient is going to be contact lens intolerance, but one mandate is they should have at least a corneal thickness of 450 micron at the 6 millimeter optic zone. So then again, we need to plan which Intac, what is the thickness of the Intac, what is the different dimensions. This is based on the pre-op spherical equivalent, the location of the cone, the amount of asymmetric astigmatism, and then you would decide the number of rings. Now, if you see in this map, if the location of the cone is such that 50% of it is within the 3 millimeter zone, then you call it centered cone. Whereas in this other map, where 50% of the cone is outside the 3 millimeter ring, it's a decentered cone. If the centered cone, you would use symmetric Intac ring segments, and that would be based on the spherical equivalent of these eyes. And it will tell you whether you use 0.210 or 0.25 or 0.30, but they will be symmetric equal thickness segments on either up above and below. But if it is an asymmetric cone, then you would look at the cylindrical part and you would plan to use a thicker segment inferiorly and a thinner segment superiorly. But if there is a large, great, significant astigmatism only, you would use shorter segments, and even sometimes you would use a single segment which would have a greater local effect. Now, this was a case of a patient with frank iatrogenic ectasia, and you can see -6 with -5.75 with 110-degree axis. This patient underwent Intacs with cross-linking, and believe me, this patient achieved a visual acuity of 6.9. Though, of course, this is not to be consistent. We cannot promise this patient, but definitely this was as successful in this particular eye. The purpose of doing the Intacs, as I had already alluded to, is to displace the corneal apex to a more physiological position and then cross-link it and lock it into that position, and it makes sense to combine. But supposing you have already cross-linked this eye and the patient comes back to you with a significant irregular astigmatism, then you could still go ahead and place the Intacs, but you need to remember that you need to increase the energy on the femtosecond laser platform to allow the creation of the channel, and there may be a little difficulty in insertion of the Intac segments, and there could be some amount of haze in these eyes. The other thing we also understand that if the treatment is done simultaneously, the newly dissected femtosecond channels allow greater pooling of riboflavin, and there is a more exaggerated flattening with cross-linking. Now, having crossed that, then you decide that this is the way to go. Then over and above, if the patient has a little residual error, then you could think of fitting different contact lenses on these eyes. If there is a possibility, you could even do a PRK for this residual error, but you need to remember that there could be epithelial hyperplasia which should occur along the Intac segments. But if the residual error is more, you would do Intacs and cross-linking in these eyes, and then wait for the topography to stabilize, the refraction to stabilize, and then you would plan a phakic ICL in these eyes. What essentially you have a well-centered ectasia, the Intacs have been placed, and now you need to give him a good BCVA or probably a good uncorrected vision acuity. And after a period of wait of 6 months, you create the side ports and then go in and inject a phakic toric ICL or an IPCL in these eyes and take care of this visual acuity. But then, supposing the cornea is hazy, all this could be suggested if the visual axis was clear. But if the cornea was hazy, you have the only option to go in for a DALC procedure, and this would be done absolutely beautifully by any of our corneal surgeons. But then we need to keep in mind that once the surgery is done, the question starts all over again about visual rehabilitation. When would you remove the suture? Would that alone be enough? Would you need to plan a phakic ICL later? And so on and so forth. But the essence of my talk here is, this patient came to you with a vision of 6/6 for a laser vision correction, and you promised him the sky. He incidentally developed an iatrogenic ectasia. So don't you still owe this patient a 6/6 vision or a near 6/6 vision, a near uncorrected 6/6 vision, or at least a best corrected vision of 6/6 or 6/9? And for this, we need to keep in view the whole management algorithm which I suggested, because I think it's our duty to our patients to judiciously plan specific to each of these cases and define a combination therapy. And I promise you, you would get the most optimal outcomes in properly selected cases. Thank you. And having said that, I'm sure you would have some questions to ask. How far is collagen cross-linking in stabilizing the disease course? Definitely, I would like to do a cross-linking as the first instance if I come across a patient of iatrogenic ectasia. See, essentially, there are different gradings in the score analyzer based on the refractive error, based on the amount of asymmetric astigmatism, and based on the age of the patient and more factors which have to be looked in. And based on that, you can grade them as grade 1, grade 2, grade 3. And accordingly, you would be justified in, you would actually, when in a very early case, maybe if the vision has not got affected and hardly any irregularity, astigmatism, you would just do a cross-linking. But as it moves on, you would plan whether you would cross-link it with Intacs or you would have to go further and even do a cross-link with Intacs and a phakic ICL. What is the other question? Is a patient with an altered tissue percentage at risk? Definitely, I would look at it as a major risk factor, as not the 100% occurrence, but then I would not take any chances with these young guys, and I would definitely look at doing something other than a corneal-based procedure. How are the risk profiles determined? Now, if a patient has an ectasia after keratorefractive procedure, I would view him as I would view any keratoconus eye. I would not have a very special nomograms or special management. Specific to what I had discussed, I would follow that system of dealing with these patients. Genetics definitely has a role. A family history of keratoconus should have been asked in our primary history before we take up these patients for undergoing a thing. And some of these patients are habitual rubbers, which has to be also kept in mind. I would tell every single patient of mine never to rub the eyes after having done a laser vision correction. And I even tell them that even normal eyes, if they rub, could be prone to it, but you are far more susceptible to it. I would never miss out on telling every single patient of mine. Can pregnancy trigger a late? Yes, definitely. Pregnancy, during the pregnancy period itself, if you have already undergone a laser vision correction, has a very rare possibility, or even a normal eye for that matter, is a rare possibility of developing an iatrogenic ectasia if they are prone to it, or it was a form fruste keratoconus which was not diagnosed before they came to you. Maybe their first visit after pregnancy, they've come to you. So definitely, we need to be very cautious, and we would not treat patients who are pregnant for a laser vision correction because you're not sure how the hormonal changes during pregnancy would take forward. So I seem to have answered some of your questions which came up relevant to my talk, and they were very relevant questions. Thank you. Finally, before I conclude, I would want to share a most happy news with you all. I had actually been traveling I was elected as a member scientific committee 3 years back, I was so rejoiced with it. And under Dr. Lalit Verma as a scientific committee chairman, we scientific committee members were given great encouragement to do our best towards the scientific content of the whole meeting as a whole. But that sort of energized me that I should not stop with it and go forward. And I followed it up with nearly 2.5, 3 years of very active traveling and going for meetings and meeting many people. And I was so fortunate to come back home with the most positive experience and so energized and happy. And then came the elections, the online voting and the on-site voting, and was so delighted last evening to have managed to win the post of chairman ARC. And I'm so grateful to one and all of you for having elected me for this. And I promise you that I would do my very best to make you feel happy that you elected me and do something forward towards Chairman ARC. Thank you.